All right, so it is my pleasure to introduce our speaker, Dr. Robert Wright. Dr. Wright is the chair of the Department of Environmental Medicine at Mount Sinai. He received his medical degree from the University of Michigan and completed his pediatric residency at Northwestern University. He completed fellowships in pediatric emergency medicine at Brown Medical School and medical toxicology, environmental epidemiology, and genetics at Harvard. Dr. Wright started his career at Harvard and joined Mount Sinai in 2012, where he established the Lautenberg Laboratory for Environmental Health and co-founded the Mount Sinai Institute for Exposomic Research. The institute includes a center for geomedicine that links maps of environmental factors, including air pollution, temperature, green space, and built environment with human health data. Additionally, he has published over 500 research manuscripts and has served on numerous national and international boards. He has also established the Programming, Research, and Growth, Obesity, and Social Stressors, a longitudinal birth cohort in 2007 based in Mexico City, in which he studies the developmental origins of health and disease. Please join me in giving Dr. Wright a warm welcome.
Thank you. I think this will probably be a very different grand rounds than what you're used to, so I hope that's a good thing. So I think in my original title, I referenced a Joyce Carol Oates story called Where Are You Going, Where Have You Been? I changed it to a Flannery O'Connor story, Everything That Rises Must Converge, which is actually a story about generational clashing, but also a story about the effects of racism on society. So some of that I think actually is relevant to today's talk. So I have no financial conflicts of interest to disclose. So I'm going to start by defining the exposome and how it is measured. I'm going to take a guess that many of you are not familiar even with the term exposomics, so I need to start with the definition. I'll define precision medicine, which I think you're probably much more familiar with, and then I'll talk about the differences between public health research and clinical research and how we might apply exposomics to clinical medicine. So because now is the time to converge. So what is exposomics? Exposomics was first described by Dr. Christopher Wild, who works at IARC, the International Agency for Research in Cancer in France. And he defined it as the study of all the health relevant environment across the lifespan. So from conception to death. So it's a big space and it includes everything. It only doesn't just include chemicals, which is where I started my work, but also nutrition, the green environment, the social environment, infections, light at night, sounds such as noise and its impact on health, and even things like pollen. So it isn't just chemicals, it's everything, literally and across time. So it's time varying. The technology actually to measure the exposome, though, may be more advanced than you realize. So it's actually a field that's been sort of slowly building over the last 20 years. And it's different than all the other omics sciences because it requires the integration of different data types. So it includes questionnaires. You really can't get to the social environment right now without questionnaires. There's no biomarker for how you feel. It includes GIS and model building, understanding the role of place in health, and I'll get into that a little bit more. It also includes things like photographs, so that we can actually define what you're being exposed to. We actually often ask people to take photographs of what they use to clean their homes, so we have a sense of what kind of chemicals they're being exposed to and cleaning their home. It includes biomarkers from blood and urine, and it includes wearable devices, accelerometers, environmental sensors, et cetera. So it really requires integration of many different types of data. So how do we know that the exposome is important? Well, it turns out your zip code is a better predictor of your health than your genetic code. So this has actually been known. In fact, it always puzzles me why we're focusing so much on understanding genetics when we already know that zip code plays a more important role in our health, and yet we don't make an effort at understanding the role of place, which is really what zip code is about. Zip code is a proxy for income, social environment, and environmental pollution, and even diet. So all of those things correlate with zip code, and that's why zip code predicts your health. That's the exposome. What exposomics really is trying to measure those factors directly, rather than using a proxy like zip code, income, or race. And if you need some more convincing, no less than Francis Collins Unfortunately, he waited until he left NIH before he conceded that environment might play a role, but he said that your likelihood of having a certain lifespan depends heavily on the zip code and where you were born, and that's a reflection of environmental exposure, socioeconomic, social determinants of health, et cetera, et cetera. That was his exit interview in 2021. So how do we measure the exposome? Well, there's lots of different technologies, as I alluded to. There are laboratory assays that can be run on blood or urine, and they can measure nutrients, chemicals, metabolites, toxins. There can be targeted, which is a term you'll often hear. Targeted means that it's quantitative, but it tends to be a small number of chemicals. So a blood lead level is a targeted assay. And there are non-targeted or untargeted assays. These are more the like microarrays. So you're measuring thousands and thousands of chemicals, but you don't really know their concentration. You know they're there, but you don't really know the exact quantity of it. But it's semi-quantitative. You can actually get a sense of how much is there relative to the others, but it's not truly quantitative. There's been some interesting work actually in our laboratory. One of our faculty, Dr. Manish Arora, who's a dentist and a chemist, actually developed an assay using teeth that now he's using actually to diagnose diseases and going back in time. So teeth, it turns out, grow like trees. So there are growth rings in your teeth that were formed when you were a fetus and are actually forming even today. And there are ways to actually add calendar dates to those growth rings. Obviously, they're tiny, they're microns in width, but with new technology, you can actually measure chemicals that were deposited in rings and attach a calendar date to it. So it is information on past timing. And there was the external exposome. So these are temporal spatial models that are built from public databases. This is how we measure air pollution and climate. We can use satellites or drones. We can measure stress, light, and noise using monitors or wearables and crowdsourcing. They typically don't have an assay, but they're an experienced environmental factor. So we don't want to exclude things like light and noise and stress and air pollution, even though we can't measure them in blood or urine, but we can do that with temporal spatial models. And then there's the social exposome, things like stress, your ability to cope or resilience, violence or social supports. Most of these are actually still measured by questionnaires, although there are ways to get at some of this data through geospatial modeling, such as the built environment. But one thing that's common to them is they can still be mapped. Even if you use questionnaires, if you know somebody's address, you can actually attach a value in geospatial time. And so a lot of what we do is actually in the laboratories. When we measure the internal exposome, we get chromatograms like this. This is a chromatogram from an untargeted assay that shows the thousands of chemicals found in a blood sample. And each of them is a unique chemical that we can actually tell whether or not it's present, and we can give a relative concentration of what it is, which is actually very important because a lot of times you're not even aware of what you're exposed to. So we can actually tell you what you're being exposed to. As I said, it measures thousands of chemicals. It includes things like ultra-processed foods, which I think are going to get more popular in terms of studying in the future, but also consumer products and what's in our air and water. And then there's geomedicine, which is really a new field arising from exposomics. And this is all about developing models that actually tell us what the temperature or climate is in a geospatial area, but also across time, as well as things like exposure to green space and air pollution. We can even model social media content. So in the lower left here, this is actually a model based on Twitter and using natural language processing to tease out mean words, so to speak, and to show where you're actually seeing a higher number of mean words in tweets versus other areas. Then there's also ways to get at how you feel about your neighborhood. So this was a questionnaire on neighborhood sentiment and safety index, which was then mapped across the state of Massachusetts. And then you can also model things like traffic patterns and noise. So pretty much everything can be placed on a map. And that's important because remember, zip code predicts your health better than your DNA sequence. So understanding the geospatial relevance of all these factors is clearly important. What exposomics is about is trying to tease out which one of those are the more important ones or which one of those are driving the relationships. Then there's wearable devices and the Internet of Things. So all of you probably have a phone app. That means that Apple or Google knows where you are right now. They also know whether or not you're indoors based on the signal strength. So we can actually map where people are. In fact, it is happening. It isn't theoretical, it is happening. And if we know where people are, if we add that to those models, We have a much better or more refined estimate of how much air pollution or whether you experience climate change or whether or not you're experiencing all those different models. So that's actually made possible by cell phones. And it's something that's actually happening sort of passively. And if we understand that with the wearable device, it may give you some information on your heart rate and your respiratory rate, which is actually what Apple is now starting to do. We can actually intertwine the environmental factor and the physiological response. And then there's one other aspect of exposomics that sets it apart from genomics, so windows of susceptibility. So this is really the intersection of environmental exposures and developmental biology. So I'm a pediatrician, so I'm very interested in this area. So we know from developmental biology that certain genes are turned on at certain ages and they're turned off. If that coincides with an environmental exposure, that can have a health effect that's specific to that life stage. The example I typically give in class is if I'm exposed to a chemical that stunts my growth when I'm 2 years old, I may end up shorter. However, if that same chemical exposure happens at age 30, nothing's going to happen because I'm not growing anymore. And that happens in a lot of different factors in the ways that our bodies develop, including our brains. In fact, the developmental windows field actually grew out of language development and whether or not certain exposures at certain ages actually predicted language development. In the field of teratology, the most common example given is thalidomide. So thalidomide is a chemical that was used to treat morning sickness in pregnant women. And it was very, very effective in treating morning sickness. Unfortunately, it also caused birth defects, micromelia or aphasias of limbs that happen. It was actually predictable how bad the micromelia would be based on the age at which, the fetal age or gestational age at which the woman took the medicine. So this is another example of windows of susceptibility, which can be quite small. They can be as short as a few days. So that's exposomics. So it's all of the environment across time and its intersection with developmental biology and how it sets a life course trajectory of health. So what is clinical environmental research? So most environmental research is public health research. And so I come out of a public health world. So most of my research has been in public health. I'm trying to move more towards clinical research because I think it's an area that's long been ignored. So I break down environmental research into 3 areas. Basic science, which is often basic science toxicology, which is how biology works. It might be in silico, it might be ex vivo, it might be in vivo animal models, but it's basic science. And then there's public health research, which is really how can we prevent a disease and promote health in populations. And this clinical research, which is how do we treat individuals with a disease. Clinical environmental research has largely been non-existent. So I'm going to give some examples of how we can actually bring environmental health into clinical research. So this is where I get to precision medicine, which is really about how can we give better, more informed and specific treatments to patients. Precision medicine started out as pharmacogenomics, almost exclusively. It's starting to branch out more. But initially, the idea was if we sequence your genome, we'll know which drug to give you. Those drugs will have decreased exposure to ineffective drugs, will lead to targeted therapies and targeted behavioral interventions, improve counseling, improve treatment decisions, improve adherence, and reduce complications. That was the theory. But the reality is genetics is only one piece of a much larger disease puzzle. And the diseases that are most important to the US healthcare system are what are called complex diseases, because these are the diseases that drive healthcare costs. If we added exposomics to precision medicine, we could actually complete the puzzle. So this is actually the cover of Science in 2002, the April 29th or 26th edition. And it was all about the puzzle of complex diseases. So complex diseases are things like Alzheimer's disease and asthma and autism, and almost all the cancers are complex diseases. They're all the non-Mendelian diseases and the non-infectious diseases. So they're the diseases that have multiple risk factors for them. And genetics does play a role. There was articles on genetics, but the issue actually was much broader than that. Now remember, this was before the Human Genome Project took off. It was completed by then, but genetics really hadn't dominated the scene yet. That actually happened a few years after this. So at this time, things like behavior, nutrition, chemicals, infections, physical environment were all considered part of the complex disease puzzle. And in fact, the introduction to the issue was it's not just the genes. So we've known for a long time that complex diseases are by definition complex, but we've been focusing, I think, too much on genomics to the detriment of environment and what I'll call exposomics, which is the environment defined broadly. So what else was missing? So in order to do research that will affect clinical treatments, you have to understand the difference between research about causes of diseases and research on how to treat a disease. And it's actually a subtle difference. Not all health research impacts clinical care. And everyone understands that basic science is a couple steps removed from clinical care. You can't go straight from an in vitro study to a clinical intervention. You have to try this out in animals and human beings first. But what about public health research? We tend to think of that as being relevant to clinical research. So here's a clinical research perspective. Help me diagnose the patient. So public health research can help. Risk factors are a weighted variable. I'm a 61-year-old man. If I have chest pain, I present to the emergency room. Particularly if I was a smoker, the assumption would be that all those risk factors predict that I'm having a heart attack. So they can help in diagnosing the patient. The other aspect is help me treat or care for the patient. Public health research actually doesn't help that much. Often the results are even ignored. If I am having a heart attack, the fact that I smoked or I breathed air pollution doesn't change what's going to happen next. I may get a cardiac cath, I may end up with surgery, I may end up with a stent, but the fact that I smoked and the fact that I breathed air pollution, which are risk factors, doesn't change anything. And that's the disconnect. So a lot of public health research actually doesn't impact treatment. And there are no right answers to the wrong questions. So Ursula K. Le Guin is a famous science fiction writer. She wrote the Earthsea trilogy. I like to put in a lot of literary references in my talks. So public health research versus clinical research. So I mentioned that there's a difference between populations and individuals, but it's actually more than that. There's a time difference. So in this graph, the x-axis is time. So public health research takes place on the left-hand side of the x-axis before the disease occurs. So at this little notch here, that's the onset of disease. So in public health research, we're looking at healthy people, and we're trying to understand why they go from being healthy to being unhealthy so that we can prevent a disease. That's what public health is about. Clinical research is different. Clinical research, people already have a disease. Prevention doesn't matter anymore. It's interventions, treatment, or reducing the onset or progression of a disease. So it happens after the disease. So there's a time difference as well in the difference between public health and clinical research. And clinical research tends to be either randomized controlled trials or observational studies in groups of patients. And that's true for both genetics and environmental research. Public health, as I said, is about prevention, and research occurs before the disease onset. Clinical research studies occur after the disease onset. So that's the other distinction. So here it is in practice. So why is this precision medicine and not public health? This is actually an example you can find on almost every precision medicine website. A 53-year-old develops a DVT on a trans-Pacific flight. She develops a GI bleed after starting a standard dose of warfarin. Does anybody know why this happened? She has a genetic variant that makes her a slow metabolizer of warfarin, so she needed to have her dose adjusted. And it would have been picked up with a genome scan. That's a classic precision medicine example. This is an example of somebody I actually took care of once. So a 24-year-old with autism has a gradual increase in head banging and anger outbursts. There's no genome scan that's going to tell me what's going on. However, it turned out that he had lead poisoning. He's a 24-year-old with lead poisoning. The reason that happened is because he has autism. People with autism have pica. They eat non-food substances. Turned out, this was the 1990s, I'll start with that caveat. He was eating newspaper. The ink in the newspaper had lead in it. He ate enough of that newspaper ink that he developed severe lead poisoning, and it made his autism worse. He had violent outbursts. His parents found him hard to control, which was new for him. But that was an intersection between environment and disease, and that's a clinical disease, and we actually treated him with chelation. In both cases, the disease is already present when the risk factor occurs. Genetics did not cause the DVT. The genetic variant in the P450 system is not a risk factor for a DVT. It affected the treatment. By the same token, the lead poisoning in this child did not cause autism. It made the autism worse. That's why these are clinical research questions rather than public health questions. Clinical research informs treatment, not prevention. Here's another example, and I put in 3 hints in here. So a 34-year-old has gastroesophageal reflux, a history of depression, is treated with morphine for a fracture and develops respiratory failure. He recently started a health food diet involving high consumption of high amounts of fruit. A genome scan revealed no functional variants in his phase 1 or phase 2 enzymes that could have affected morphine metabolism. Does anybody have any idea what's happening? There are 3 things happening. So obviously, I put a clue in the GE reflux. So ranitidine inhibits the P450 system. Over-the-counter Tagamet does it too. So he has a history of depression. A lot of antidepressants also inhibit the P450 system. Paxil will do that. And he's been eating a lot of fruit. Grapefruit also inhibits the P450 system. So he has a phenotype that's identical to having a genetic variant in the P450 system, and he got there from environmental exposures. And that's really what I was just trying to illustrate, that you can actually get to the same place through the environment that you can get to through genomics. So here's some examples of public health environmental research. Let's say neurotoxic pesticides cause Alzheimer's disease, and there's a whole literature on this. Paraquat in particular has been associated with Alzheimer's disease and also Parkinson's disease. It's not going to help treatment if you're exposed to paraquat when you're 25 years old, maybe you're smoking weed. That's actually a true story. The CIA actually sprayed paraquat on marijuana fields, and that ultimately led to Alzheimer's disease because dead neurons are dead neurons. It's not going to bring them back to life. It tells you about the cause, but it's not going to help you with treatment. There's also a whole category of environmental obesogens. You've probably read about these in the paper. Microplastics and PFAS, P4 substances, are environmental obesogens. They've been associated with diabetes. They're thought to be a cause of diabetes. And then air pollution has been associated with stroke. There's a literature on this as well. These are all public health studies. They're not going to help you treat the patient because a patient who's exposed to air pollution and ultimately got a stroke, you're not going to change your management based on that cause. And as I said, dead neurons are dead neurons. It's, preventing it, you don't want it to get worse, but it's not going to reverse anything. So in each example, having exposure occurs before the disease, and the idea in the research is to establish causation. Most environmental health studies fall in this category. There's a big literature on all 3 of these areas. What if we slightly modified those questions? Instead of neurotoxic pesticides predicting the cause of Alzheimer's disease, maybe neurotoxic pesticides predict higher rates of weight loss and dehydration in patients who have Alzheimer's disease. Very plausible. Not something anybody actually looks at, but it's also actionable. If that were the case, you could actually take a look at what they're doing in their home and advise them to reduce that exposure. And in fact, chlorpyrifos is often sprayed in homes, particularly in poorer areas of New York City. Chlorpyrifos is a organophosphate pesticide. It's actually found in high concentrations in a lot of homes in New York because of cockroaches, quite honestly. Another question that might be interesting is environmental obesogen exposure modifies glucose control and insulin dose in diabetic patients. There's a large literature on whether these chemicals actually might cause diabetes. There's almost no literature on what it's doing to somebody who already has diabetes. Maybe some patients who require a higher dose of insulin or other insulin-releasing drugs, maybe those patients are being exposed to environmental obesogens, and if you reduce that exposure, they wouldn't need the adjustment of their dose. That's actually an open question. Nobody's actually studied that yet. Yet it seems like a very logical question, and that's a clinical question. Also, air pollution, maybe it increases the risk of seizures after you've had a stroke. So maybe it didn't cause the stroke, but maybe it's making your symptoms or your side effects worse. In each example, having exposure occurs on top of an existing disease. This is a simple shift in time from left to right in that previous graph, and yet it changes the question enough so that it makes it clinically relevant. Because in these questions, it's not about causation, it's about disease and its care. And to impact clinical care, we need to ask the right questions. Clinical environmental health studies are actually, as I said, very rare. So clinical exposomics, why now? So there have been exponential advances in exposure science in the last 10 years. We have those non-targeted assays that I told you about earlier. We have more high-dimensional targeted chemical panels. Our laboratory can measure fully quantitative about 300 different chemicals, including chemicals that are wildfire metabolites, as well as pesticides, and tell you whether or not your patient's exposed to them. We can also measure the chemicals that are found in ultra-processed food. We can give you an idea of how much ultra-processed food people are eating. With satellite remote sensing, we can build models and tell you how much air pollution is around your patient's home, whether or not they've been affected by heat waves or very cold temperatures, how much green space they have, how much light at night they're exposed to. We can publicly mine databases to look at social media, the American Community Study, which actually gives a lot of social environment information, as well as zip code and census and EPA data to get a sense of how much pollution they're exposed to or what the socioeconomic status is of their neighborhood. We can mine EHRs to look at whether or not they're taking particular medicines or whether or not they've had procedures in the past that might be affected by their environmental exposures or their disease. We can also look at their wearable devices and look at the intersection between their physiological response and air pollution and place where they are at the moment that it happens. And with the big data computational infrastructure and AI machine learning that exists today, we can actually do this much better than we've ever been able to do in the past. So more examples of clinically relevant environmental health research. So maybe air pollution predicts 5-year mortality post-lung transplant. So in most cases, moving is probably not realistic for people. If you're telling me that I have a higher risk of getting lung cancer, for example, and there is some literature on cancer and air pollution because of the air pollution that I'm breathing in New York City, but I'm a healthy person, I'm probably not going to move. If I've just had a lung transplant and you tell me it's going to reduce my 5-year risk of dying or increase my 5-year risk of dying, I might actually move. That might actually be clinically actionable. So also I would definitely get HEPA filters and start to breathe clean air inside my home at least. Also, we don't understand the role of diet in drug treatment failure. There's all kinds of chemicals found in food that affect the P450 system. Those chemicals may actually be affecting the metabolism of the drugs that we give our patients. Nutrients can alter the P450 system. Grapefruit juice is actually a very common one for inhibiting the P450 system. And it could affect things like chemotherapy. You can also look at the role of heat waves in drug treatment failures. Heat waves are stress on the body. You metabolize differently when you're stressed. There's ways to actually take a look at that through existing RCTs or even observational clinical data. PFAS is a forever chemical, perfluoroalkyl substances. These are the ones found in cookware. They're often contaminated in drinking water, even in municipal drinking water. They get stored in the liver. Maybe they're actually predicting the progression of liver failure. So if you have a patient who has alcoholic liver failure and they have high exposures to PFAS, the PFAS might actually be making it worse. But in each example, having the existing disease is the susceptibility factor. So how do we operationalize bringing exposomics to precision medicine? Well, we should start looking at these exposure assays in cohorts of patients longitudinally so we can understand the effect of the environment on the disease. And we can predict the risk of complications that occur during treatment, predict patient responses. Maybe some of the treatment failures are actually due to something that's in the environment. And again, we can do these either in observational studies using clinical cohorts of patients or nest them in randomized controlled trials. Study design matters. We want to look at people who already have a disease. We're not trying to prevent the disease in this case. We're trying to look at the effect of the environment on the disease itself. So what are some barriers and what we need? Well, the biggest barrier is probably time. The average outpatient physician visit is about 15 minutes. So how are we going to add all this information? So also, I'm very cognizant as a physician. I used to practice emergency medicine. There's a lot of information overload. Omics data has this problem. Genomics has this problem. That's a lot of information to try to distill in 15 minutes. Physicians need a way to be able to do that. And there's a lack of training in environmental health. How many of you know what PFAS is? Have you heard of microplastics? Can you name a microplastic chemical? So, phthalates and bisphenol A. I think if I said it, you might actually know that that's a microplastic. Those are endocrine disrupting chemicals. They've been associated with diabetes. So we never look at them in patients who have diabetes. So if you have a patient with diabetes whose diabetes is hard to control, it might be something in their environment. Also, how do we interpret risk and odds ratios? Most public health research talks in a language that doesn't really apply to clinical medicine. An odds ratio of 3 might be the difference between a risk of 1 in 100 versus 3 in 100, or 1 in 10,000 versus 3 in 10,000. In both cases, the odds ratio is 3. But your approach might be very, very different if it's the difference between 1 in 10,000 and 3 in 10,000 versus 1 in 100 and 3 in 100. I'd be very worried for the latter. I wouldn't be as worried for the former. So we need to understand how to interpret these different risk factors, as well as the health effects of environment. So we need diagnostic tests that use exposome technology. I think untargeted assays can be really useful for understanding eating disorders like bulimia or anorexia, because that will cause a radical difference in the metabolism, and those untargeted assays actually capture metabolites. We also need environmental health findings that are clinically actionable, so we need to do studies that actually apply to patients. But we also need systems for health literacy and results translation. We need something along the line of up-to-date for environmental health. So we need an exposome knowledge database. There are some for genomics. Online Mendelian inheritance in man is actually quite good. So if you want to understand what a gene does, you can just Google it and look it up in OMIM, and you can actually get a really good sort of summary of what that gene does. There's no such thing for exposomics just yet. And then ultimately, we want this information to be taken up into something like UpToDate or a similar platform so that it can be easily translatable to clinicians and healthcare providers. So maybe in the future, maybe 10 years, it's probably optimistic, a doctor's visit might look like this. So maybe you'll hand a wearable device at the clinic in, and they'll download it, or maybe you'll download it securely at home, and it'll give information on where you've been, with your consent, obviously, how active you've been, how mobile you've been, what the air pollution is in the places you've been, what the temperature your experience was, what the physiologic data in response to that temperature was. You'll also have your address history, where you've lived, going all the way back to where you were born. So I was actually born in Okinawa on a military base. My father was in the military and my mother was Okinawan. I probably got exposed to Agent Orange because this was during the Vietnam War. And if I look it up, I can actually find that there was lots of dumping of Agent Orange around the military base where I was born. That's not something that would be known otherwise, but it might actually play a role in my health 60 years later. So that's something to think about in your patients. If we understand the role of place in health, we can actually start to use place when we start to diagnose patients and take care of them. So we'll also want to know your education, your travel history, your occupational history. There are questionnaires that can actually estimate what you're exposed to based on what your occupation is and what your job duties are. Those are called job exposure matrices. We can download surveys on the social environment into the electronic health record at the front desk on a tablet. And then in the background, we can use AI or machine learning to generate risk scores from a combination of what environmental exposures you've had across your lifetime, as well as your genome data that already exists in there. And we can factor in your age, your diseases, your exercise level, et cetera, to get a much more accurate reflection of what you're at risk for. We need a really large infrastructure, obviously, to do this and to systematize the data, information transfer and interpretation. Research isn't enough, but this is actually very, very doable. Just right now, the will to do it doesn't quite exist. So other benefits of bringing exposomics to clinical care, not only will we identify drug-environment interactions, which are a lot of the examples that I gave, and environment phenotype interactions like air pollution making patients with Alzheimer's disease worse in terms of their symptoms, and bringing in exposomic information that is actionable. One of the biggest frustrations in public health is getting people to change their behavior, getting people to quit smoking, for example, who are healthy before they have lung cancer or heart disease. So after you've had a heart attack or after you've been diagnosed with lung cancer, you're far more likely to actually quit smoking. If we give environmental information how to reduce exposure to people who have diseases, with the idea that it's going to help their disease, they're far more likely to do that. And we'll have a better understanding of the impact of these environmental interventions. So in the future, I think exposomics and precision medicine will enable more diagnostic tests, enable us to understand the effect of chemical, nutritional, physical, and social environment on the severity of the disease and the progression of a disease. It'll help us identify the optimal treatments based on the exposome of a patient at the individual level. And we'll have a better understanding of a response variability due to the environment, as well as side effects, which may be occurring because environment-drug interactions. And then we can complete the complex disease puzzle by asking the right questions. So I'm going to give you a brief summary of what we do here at Mount Sinai at the Institute for Exposomic Research. So we're part of a program funded by the National Institute of Health called HERE, the Human Health Exposure Analysis Research Program. That funds our laboratory. Our laboratory can do the untargeted chemical assays that I told you about, where we can actually measure thousands of chemicals in a biological sample of urine or blood. We can also tell you about ultra-processed foods. There are chemical signatures. Oftentimes the dyes and preservatives in there are unique chemicals. They're not food, so they're not found in normal nutrition. So we can also give you an idea of your metabolomics, but also whether or not you're eating a lot of ultra-processed foods. We have novel biomarkers like the tooth biomarker that I told you about. Works great in kids because kids lose their teeth starting around age 5. Doesn't work so great in adults since we do have to have the tooth. However, there's some work that's being done with brain banks and other types of biological biobanks where we're trying to get teeth post-mortem. So we can get lifetime exposure information with that tooth. We can measure trace elements and heavy metals. We can do targeted assays on thousands of different types of chemicals. And we can actually integrate this if you're doing research on epigenomics or genomics as well with the larger picture of your study. These are some of the chemical assays that we do. So there's hundreds of them. We can look at smoke. Some of these are specific to wildfire, so we can actually look at wildfire. If you remember that day about 2 years ago in June where it got dark at 2 p.m., if we had a sample from those days, the days after, we could actually tell you whether or not you were exposed to wildfire and had samples from other days. Some of the work we're doing actually uses hair to do that. So hair grows at about 1 centimeter a day, and you will actually deposit chemicals in hair. So we can actually look at whether or not we're working with a group at University of Southern California because of the wildfires that occurred there in December, and we're actually collecting hair. And we're looking at chemicals in the hair to see how much wildfire they were exposed to. We can also look at nutrition, as I mentioned, ultra-processed foods, as well as biological response assays. So we've developed what we're calling a GeoServer with CTSA. This is mapping the intersection of place, environment, and health. As I mentioned, your zip code is a better predictor of your health than your DNA sequence. And so we're trying to understand what it is about place that actually predicts health. So it's, as I mentioned, it's a proxy for air pollution. It's a proxy for weather and allergens, and even socioeconomic status. And all those factors play into zip code. Zip code itself isn't actually causing the health effect. It's all those things that actually correlate with zip codes. So we're trying to deconstruct what it is about zip code that actually predicts health so well, so that we can actually employ that in your research. And I hope I've convinced you that environment is important. And this slide is actually from a novel called Neuromancer. It's another science fiction novel. Some of you might be familiar with it. Some people think it's the inspiration for the Matrix movies, but it was about people living inside a computerized system, and it was actually written in the 1990s. And there's a quote from this novel: "The future is already here. It's just not very evenly distributed." In other words, we can do all the things I talked about, but right now it's not evenly distributed. We're not bringing it together. The technology exists. The will to bring all these things together and bring them into the clinic is what's missing. And so hopefully in the future, we'll be able to do that and get a better sense of how environment affects health. That's my last slide.
Thank you. I think as folks are thinking of questions, I'd like to go back to the zip code. I'm fascinated by the zip code concept, and how are you operationalizing the zip codes as predictors? Are you looking at the zip code of where the person lives right at that moment? Or are you able to look to track people across? How are you really using that? Because where a person grows up may not be where they live, and then they move, and then is their life expectancy shifting with the zip codes they're living in?
So that's a great question. Almost all the studies are only asking you where you live now. Very few studies have asked for residential history. So it's kind of an open question. The studies that have looked at it find that it's a very good predictor of health. Well, that's why Francis Collins even mentioned it in that interview. So yeah, that's still an open question. I think if you think about the developmental origins of health and disease concept, that is that environmental factors that you experienced as a child actually predict your health later. So some of why you had a heart attack at age 60 is your diet, potentially even your mother's diet when she was pregnant with you. And that was actually something that's been described since the 1980s, but it's never really been studied effectively on a large scale. So I think that's an open question. And I think we know that zip code where you live now predicts health. And we also believe that zip code where you lived as a child probably predicts health, but very few people collect it. It's a very unusual thing for a researcher to ask, is your residential history, where it should become standard because it's clearly a predictor.
Thank you. Dr. Kraft? Very nice. Sorry, I was a little bit late. I was listening to you on Zoom earlier, and you made a point of this. So I was thinking about how using an AI algorithm around this would make a lot of sense in terms of all the layers of data you have, but also just to follow up on your comment, Adriana, about the shifting location and how that sort of provides a node of influence that could kind of become part of the layer of complexity of data to really predict outcomes. So I assume, are you sort of thinking, are you probably
Yeah.
on that? Yes, but just wondering how far along are you?
Oh, yeah. No, we use AI and machine learning in these analyses because these relationships are seldom linear. So by using AI and machine learning, you're not forced to assume linear relationships. And also the complexity is just too much to actually assume that you know what the model fit looks like. So we do use it. So.
And you translate it, see how you translate it as clinical care, right? If you had sort of a set way of particular conditions that there was an approach, like even a phenotypic or some way that you put in the risk factors to sort of get a score.
Yeah, no, I think in the end, people are starting to do polyexposomic risk scores, sort of like polygenetic risk scores. Where I think we've always fallen apart is this sort of nature versus nurture paradigm that exists, which in my opinion is completely false because it's impossible for genetics not to involve environment and vice versa. So every environmental factor a person exists interacts with that person's genome, and every genetic variant that person has is interacting with the environment. And if you think of phenylketonuria, is that a purely genetic disease? Well, I can prevent the phenotype if I change the diet. I mean, I don't think there's an example of a genetic disease, even the Mendelian diseases, in which there isn't an environmental component that's driving it. And I think the real difference is whether or not that environmental component is common or not. So if you think of things like sickle cell or cystic fibrosis, the environmental component is oxygen or sodium and potassium. You can't avoid those. If you can't avoid them, then it's purely driven by the genetics. But if your genetic variant is interacting with something in the environment that's not ubiquitous, that you can avoid because it's not necessary for life, those are the genetic risk factors that are largely hidden. And unless we measure the environment, we'll never see that there's a gene-environment interaction. If we just do genomics to the exclusion of environment, that's why all these genetic risk factors have odds ratios like 1.5. And they need 1 million people to have a statistically significant result, is because the environment isn't being measured. And if you don't know the environment, you don't see that if you had both the risk factor in genetics and the risk factor environment, the odds ratio might be 10 or 15, but you'll never see that.
Other questions? Are there any questions on Zoom? Well, if there are no further questions, thank you so much.